Hi, Dr. Brian Kaufman, a retired family doctor and a CLL patient myself. I am the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society, and I'm presenting some important abstracts from ASH 2023. And this one is on the outcome and sequencing of targeted therapies in CLL in the real world. And what's the bottom line? In real world data, outcomes were equivalent in chronic lymphocytic leukemia patients, whether they were treated first with Venetoclax or with the BTK inhibitor. This information was presented by Dr. Nadine Kutsch of Cologne, Germany, along with other German and other colleagues. The abstract is entitled Outcomes and Treatment Sequencing of BCL2, that would be Venetoclax, and BTK inhibitors in chronic lymphocytic leukemia, analysis of patients' data within the German CLL study group, that's GCLLSG registry. It was presented in San Diego, California in December 2023 at the American Society of Hematology's annual meeting. In the way of background, Venetoclax is the only BCL2 inhibitor that's approved to treat CLL. And there are a few approved BTK inhibitors at this time, ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib, though it is unlikely pirtobrutinib was included in this trial. These treatments have revolutionized the care for CLL patients, but there are unanswered questions about which therapies should be used, in which order, how they are used outside of clinical trials, and what's the best sequencing overall. So what was the methods and who are the participants? Real-world data from the German CLL study group registry was gathered from multiple sites in Germany to collect information on CLL patients with one or more first-line CLL treatments between July 1st, 2014, so going back almost 10 years, and January 30th of 2023. Patients who had been treated in a clinical trial were excluded, so this is strictly real-world data. So what were the results? Who are the patients? There was a total of 274 patients which were treated with Venetoclax-based therapy as their first therapy. Median time as their first novel therapy. Median time from the first documented Venetoclax treatment, irrespective whether it was given first line or in a subsequent therapy, was 26 months. Median age at the time of first treatment was 71 years. 172 patients, or 62%, were male, as we'd expect. Looking at the genetic testing, unmutated IGVH status, or deletion 17p, TP53 mutation, 11 out of 58, 19% that could be assessed, were in the very high risk category. 914 patients had a BTKI as their first novel therapy. The median observation time from the first documented treatment was 78 months for the BTK cohort, so quite a bit longer than the Venetoclax cohort. Median age was 72. Again, 68.6% were males. 46 of the 145 evaluated patients, or 31%, were in the very high risk group. So let's look at these groups in a little more detail. A little over 55% of the Venetoclax cohort received Ven as their very first treatment, and 38.5% of the BTKI cohort received the BTKI as a first-line treatment. So looking at all the 222 prior therapies before their first Ven and the 1,090 treatments before the first BTKI, chemotherapy was the most common at 70% for the Ven group and 68% for the BTKI group, followed by chemotherapy, which was 10% and 17% respectively. There really should have been no role for chemo, but it's not surprising as this data looks back 10 years, and that was still being used at that time. More encouraging and more significantly, subsequent therapies following the first of either Ven or BTKI treatment were almost exclusively targeted therapies. There was 37 subsequent therapies in 26 patients who received Ven. 10 of those were given Ven again, and 13 were given a BTK inhibitor. For those who received BTK first, there was 393 subsequent treatments administered in 264 patients, of which 146 included Ven and 106 included a BTKI again. So what were the outcomes? The median event-free survival, so this may be a new term to some people, is defined as the time from randomization to an event, and an event is either progression of the disease or death to any cause. For Venetoclax, the event-free survival, the median event-free survival, or EFS, you may see it called, was 38.1 months, with an estimated 2 out of 3 patients being event-free at 2 years. The median time to next treatment was 63.7 months. So even though an event came, something happened, like the disease progressed slightly, patients did not need treatment for much, much longer. The first event was noticed a little over 2.5 years, but patients went over 5 years before they needed treatment. The median overall survival was 96.5 months, and it's estimated that 9 out of 10 patients were alive at 2 years, with an overall survival rate of almost 90%. When Ven was given as first line with no prior treatments, the estimated 2-year survival overall survival moved up to 93% versus the 86.5% when given as a later therapy. Let's look at the BTKI group that was given, the BTKI cohort. The median event-free survival from the time of the first BTK treatment was almost 2 years, with almost half of the patients being event-free at 2 years. Median time to next treatment was 68.4 months. So these numbers are quite similar to the Venetoclax group. Median overall survival was 85.9 months, a little bit less than the Ven group, with an estimated overall survival at 2 years of 84.9%. Like Ven, the BTK group tended to do better when it was given as a first line, with the estimated 2-year survival at 92%, overall survival being 92.3% versus 81% when given as a later therapy versus for the first time. So what can we conclude? When looking at event-free survival, time to next treatment, and overall survival, they were really quite similar between Venetoclax and the BTK-based therapies, at least in CLL patients studied in this German registry between 2014 and 2023. What this research suggests broadly is that it's fine and statistically equivalent to start chronic lymphocytic leukemia treatment with either a BTK inhibitor or Venetoclax. But what it doesn't do is tease out subsets, such as those with high-risk markers or certain comorbidities or at a certain age, that might benefit from a particular sequencing. All treatment in CLL must be individualized, and to do that best, even more research is needed. Thanks very much for listening. Stay strong. We are all in this together.